Welcome to Caucus, New Jersey. I'm Steve Adubato, here in the studio to engage in a very candid and important conversation about healthcare reform as well as the current healthcare environment are Bob Garrett, President and CEO of Hackensack University Medical Center. Our good friend Patricia Costanti, Chairman and CEO of MD Advantage, which provides medical professional liability insurance for physicians in the state of New Jersey. Amy Mansue, President and CEO of Children's Specialized Hospital, and also Joe Scott, President and CEO of Jersey City Medical Center. I want to thank all of you for joining us. Amy, a couple things to clarify. Children's Specialized tied to a larger system called Robert Wood Johnson.
We're part of the Robert Wood Johnson Health System, correct.
And full disclosure, I have relationships, personal as well as other, we've done professional work with you guys, and you guys, and we've never met before, That's so correct. I'll be particularly tough on my three friends. Here we go. You ready? We talk about the healthcare reform. It means different things to different people. Amy, I'm going to ask everyone the same question out of the box. Number one concern, as we do this program at 6 months after healthcare reform nationally was put in place, biggest concern you have about healthcare reform as to what still is not addressed and why it's so important to the people watching right now?
I would say there are three concerns that I have. Children's Specialized Hospital is a facility that serves 17,000 children with disabilities throughout the state of New Jersey. For us, our main feeders are hospitals who take care of kids in trauma centers and intensive care centers in their most critical moments. If you talk about an accountable care organization, which is one of the things that's in the bill, it says that some other entity is going to manage that care.
What entity?
Well, in the bill, it talks about forming either physician groups or giving somebody the responsibility for managing that care, at least for the Medicare population, in the next 48 months. For us, we worry about how that's going to roll out as what you call a provider that has to take kids after they're in the hospital. For our kids, they're the 20% of kids that use 80% of the dollars. So they're going to be really, really sick. So if all those dollars get used in the acute care hospital to save their lives, where are the dollars going to come that I'm going to need to make sure they have a quality of life?
That's a huge issue. I know you have other concerns. I want to come back to that.
Okay.
And I want to also talk about some of the positives here. Patricia, number one concern.
Number one concern is as we have all these people who are newly insured and spilling into the system, we really haven't addressed who will care for them.
The physicians.
New Jersey specifically has a physician shortage. I don't think we've been clear in terms of how we want to begin to use other levels of professional intervention, and that creates patient safety concerns that are of great concern to us.
Sorry for interrupting. Why are they newly informed? Is it because of the legislation?
No, I think that we really haven't thought through what has to happen in terms of provision of care.
How many are we talking about?
We're talking about a shortage of about 2,800 primary care doctors in New Jersey.
Just in New Jersey?
Just in New Jersey.
And take care for how many more people who are now covered?
That's what we're waiting to see. I think that the clear numbers aren't out there.
Patricia, there's a shortage of primary care physicians to care for those who now need care. Huge issue.
Huge issue, and in addition to that, there's not a lot of incentive for someone in medical school to go into primary care because the reimbursement is really lacking.
I'll come back to you, Joe. Yeah. Bob and Joe.
The other thing, just to pick up on Patricia's point, is so you're going to have 30 million additional people conceivably that are going to be insured
because of the new law.
The new law, and yet we already have a primary care physician shortage. It's just going to grow more acute as time goes on. Another issue is that there's no real incentive for hospitals to train additional physicians because the reimbursement has been frozen at 1991 levels. So hospitals get reimbursed through the Graduate Medical Education Fund to train physicians.
For teaching hospitals.
Correct. And there have not been any additional slots that have been funded since 1991. So there's no real incentive, and the bill did not address it. It went totally silent.
Why not?
On GME.
Graduate medical...
On graduate medical education.
If it's such a huge issue, and Patricia's talking about the shortage we have already, which is only going to get more severe, why not address it? Why punt on that?
I think that I think there were so many political compromises that were made, and I think they just left that one out. They just felt they couldn't find the money or the offsets to pay for the additional training, but yet that training is so important because of all the additional people that are going to be receiving insurance.
And there are consequences.
There are consequences.
Joe, and I'll come back to Amy. Jump in.
Just to go back to the primary care issue, look at Massachusetts. There's a waiting list now for primary care appointments because there's just not enough. Everybody's got health care coverage. Actually, I think 98% of the population has health care coverage. There's a huge demand for primary care appointments, and now there's a
So what happens in a place like Massachusetts, which we often point to because we believe demographically in other ways, I don't know why we think it's similar to New Jersey, because we're Yankee fans and they root for another team up there. But more importantly, so what's happened up there?
Well, and actually, you would think that you would see a huge increase in the emergency department visits, but that really hasn't happened. So people are just waiting longer to get an appointment to see a primary care physician. So that can't be good for people who are acutely ill. And I think that's going to be a huge issue as we move forward.
Sometimes a wait of 15 months to 24 months just to see a primary care physician. And that's, if you think about it, that's what happened in Europe when they reformed their system.
You know, it's so crazy. We're doing so many shows. By the way, log on to our website. You'll find additional information on healthcare reform, the facts, and try to break through things. We're not one of those programs that tries to express an opinion, but rather bring folks with different opinions. Also, articles and other websites that can help you on this, and past clips from previous shows on healthcare. But Amy, if we're always talking about early intervention, and what I just heard was later intervention because of this wait.
Steve, you got 1 million people potentially in New Jersey who will be newly insured by 2014. Okay, that's
because of the law.
Because of the new law, and that's a positive. You said there are positives and there are negatives.
That's a positive.
Right. We've had this huge issue in the United States where all these folks have been uninsured, and so the federal government has finally said, okay, we're gonna step up and we're gonna do something. But there are laws of unintended consequences. You know, as you begin to push 1 million people in New Jersey, many of whom, I believe half, are going to be insured by a Medicaid system. Now remember, you care for your elderly, that's funded by the feds, and you aid your poor, that's through the state. So here's the governor faced with a $10 billion hole, Chris Christie, this year or in next year's budget, and the federal government has said, look, you're going to expand Medicaid, you're going to enroll all these newly insured folks, you're going to figure out how to do this with fewer people, with more pressures on state dollars. I mean, you are and providers not there in pediatrics.
Providers meaning
primary care,
primary
care docs, nurse practitioners, physician assistants.
How about specialty care?
Well, in pediatrics, we have a huge issue with specialty care.
So therefore, the feds are mandating certain kinds of coverage, certain kinds of health care, and the money is not there on the state level to do it. We've got massive fiscal problems in the state. Therefore, and by the way, we should make it clear, full disclosure also, that Amy was a top health care advisor to a previous governor, right?
I was.
Say who that was?
I was with Governor Florio during the 90s when we did healthcare reform, and we talked about the concepts of trying to ensure and make available in the small group market affordable insurance, and in the individual market to reform that. Good ideas, good theory doesn't always roll out in practice. If you look at Massachusetts, you look at New Jersey, some of those things we tried, again, there are issues that really are complicated. So I've spent a whole lot of time in the last 2 years going to Washington trying to talk about these issues. And what you hear is, look, we had a mandate to get something done. The public wants this done in healthcare reform. Whether that's true or not is a whole different debate. But the reality is it's now on us. And at the very core of it is the federal government has said we have got to find a way to reduce the cost. Now, reducing the cost means they're going to lower what they pay providers, but there's also another component we haven't talked about. It's about managing the care of the patient. My mother, I love her with all of my heart. There is nothing I wouldn't do for her. But her month is around all the doctors that she sees. You're now going to have somebody manage her care and tell her that she's going to have to see these physicians or do those things. Well, she's going to go crazy.
What's a lot going on here. I see. And by the way, Patricia, real quick, what does that mean for the physicians who care for Amy's mother in terms of the relationship between the patient and the physician?
Right. It becomes,
it's supposed to be sacrosanct on many levels.
It becomes a very disjointed and I think in some ways almost an adversarial relationship, which
between whom?
It can be between the physician and the patient pushing for more access and the physician needing to block it. We buy most of our reinsurance in the London markets, and as healthcare reform rolled out, and I go to meetings in the UK, they say, you don't have to wonder about what health reform is going to look like. You can come here and look at our system.
What does it look like?
It looks like waiting lists for everything. Do you need a knee replacement? It's a 20-month wait. Do you need some other kind of surgical intervention? It's a wait. And I think that's what we've talked about here.
Gets to my comment about the bus, the taxi, or the limo.
Yes.
I think everybody can get on the bus. I think if you want to get care in a quicker, you're going to have to pay for it. You're going to have to pay for a taxi. And if you want really kind of concierge service, you're going to pay for a limo. So, and I think you see that, you know, in Switzerland. I was talking to a U.S. citizen who lives in Switzerland and has their health care insurance. He pays $35,000 a year above for additional services.
So that's what we do. We're going to decide to what we want to pay for. Is that what it is, Bob Garrett?
Yeah, I mean, I think that, Steve, you look at it from the macro level, and I don't think a lot of people really got this when healthcare reform was being debated, but what it is a massive shift of dollars from Medicare to Medicaid, but yet the states don't really have, as Amy said before, the states, including New Jersey, really don't have the money to make that massive investment in Medicaid. What I think senior groups are finally starting to get, and why you're seeing more opposition, I think, throughout the nation to the reform, is that they're finally getting the fact that there's going to be some cuts in services for the Medicare program. Now, can providers get more efficient? Sure, they can get more efficient, but there's also going to be, in my view, significant cuts to the Medicare population.
Well, there's another thing here, and the three of you can particularly appreciate this, and Patricia understands it as well. But look, there's no secret in the state of New Jersey, many hospitals have closed, right? More hospitals will close. I'm not arguing whether it's a good or bad thing, but if you live in that neighborhood and that hospital closes, it's a bad thing, because then you have to figure out what's next. But, you and I have had this conversation, because a lot of the work that I do privately outside of my broadcasting is to work strategically in terms of how to communicate a hospital, how they communicate to the community and others when they're about to close a hospital. My point is this. With everything we're describing about national health care reform and the mandates and the pressures and the lack of funding and the reimbursement issues and the question about those who are here illegally, got to take care of them, who's going to pay for it? Yep. Here's the question. Will more hospitals close in the state of New Jersey, and what will that mean to those who are so dependent upon those hospitals? Jump in, anyone here.
And I think you're going to see consolidation also. I think you're going to see...
Consolidation's a nice word, Joe. What does it really mean?
Well, I think you're going to see 4 or 5 networks of hospitals throughout the state of New Jersey. And that's going to be it. At the end of the day, there's going to be 4 or 5. You're going to be belong to a network. That's standalone hospital.
What about you guys?
Yeah, we're a standalone hospital
freestanding
now.
Hospital.
Freestanding hospital.
Listen, I'm not blowing smoke, but the word on the street in the healthcare community is you've done a pretty darn good job tightening up the situation, economies of scale, getting
recruiting doctors and
Really, well, you can do a commercial for yourself. But my point is this: what I just heard you say is, we're doing all the right things, but come on, let's face it. Down the road, we're going to be part of Robert Wood or Hackensack or St. Barnabas. That's what I hear you saying. Because why?
I think the economics are driving it in terms of becoming more efficient. So I think there's going to be 2 factors. I agree with Joe. There's going to be consolidation where there's going to be a few major systems that will be left. But in that process, there will be some smaller hospitals that will just end off closing or downsizing significantly.
Is that a bad thing, Amy?
Well, Steve, you talk about, it's a problem for those people who access care. In those communities, those hospitals are also the largest employers. This is not just an issue of how are you going to manage your health care. These people have jobs.
I saw it at Muhlenberg, which is part of the Solaris system. They had 2 hospitals. There's JFK and, Muhlenberg. Muhlenberg closes, which is it was one of the biggest employers in Plainfield. It's not just where they go for care. It's 1,000 people, no?
Absolutely. And it's not 1,000 people in that hospital. It's 1,000 people that feed all of those stores around those hospitals and all of those gas stations and everything else. There is a ripple effect that people have not even begun to think about. I agree with you. Let's not argue whether there are enough beds in New Jersey or not in reference to hospitals. The question is, how do we want to access care and how do we want to deliver care? Joe is still going to have an issue of people who do not have citizenship who are going to show up at his door.
In Jersey City.
In Jersey City, who he's going to have to provide services for.
Absolutely.
And, given the pressures on the state, he doesn't have a choice. He's got to provide those services. Given the pressure on the state, what's going to happen to charity care? What's going to happen to uncompensated care? Public will think, well, wait a second, that was taken care of in health care reform.
We already did that.
We already did that. I don't have to worry about that. He's got those bills to pay.
We're the only hospital in Hudson County that provides dialysis to patients. So none of the other private dialysis centers will take these patients. We provide inpatient dialysis. We get nothing to provide that service.
And that's also the issue is the private guys are fighting hard, are setting up shop outside of the hospital so they don't have to take
Are they cherry
Medicaid.
Picking?
Absolutely.
By the way, cherry picking means what to folks who may not understand from a healthcare perspective, Patricia?
It means looking for the patients with the best reimbursement and not being mandated to care for the patients who don't have
But those physicians, how many physicians do you cover right now?
3,000.
Okay, it's one of the largest, right? In the country, definitely one of the largest here in New Jersey. When you're advising those physicians to survive, stay in the game in these incredibly difficult economic times and med mal insurance, it is what it is, do you say to them, by the way, what do you say to them in terms of survival mode? What is that mode?
I think right now that's exactly what physicians are trying to figure out. They're trying to think about how many more patients will I have to see in a day? How can I build efficiencies into my staff? There's a mandate to begin to use electronic health records. Can I afford them? Does it mean I have to
Well, back up. That term gets used a lot. And I don't want to open up a Pandora's box, but electronic medical records gets talked about a lot. Why is it so significant? And I know it was talked about in the bill, the health care bill. So go ahead.
Right. It is talked about in the health care bill, and I think it's it's believed to be a way to streamline and make care more efficient. It's rather than having a paper record, everything is entered into a computer system by way of a tablet or a handheld. Ideally, it's a way to communicate with the hospital system, to pull records, to be able to communicate with a pharmacy, and believed to be more efficient and to cut down on errors.
Cut down on errors, I think, is a significant part of it.
It
will make the practice of medicine safer, because when you're not transmitting vital communications by hand and you're doing it electronically, it has been shown to be a safer system.
But that's not clear, and we're seeing difficulty with that, because the way a lot of electronic health records are being used, especially in the physician's office, is with templated guidelines. So there's a template for a first visit, there's a template for a follow-up visit, and when we need to defend physicians based on those templated records, there's usually not enough there to help. And that creates an enormous difficulty, and I think we'll see that over the next several years as more and more of these cases
Someone say,
well,
what do you mean? What's the difference what the form looks like? Well, the form dictates the data you get. The data was often in a court case or whatever, what dictates how someone adjudicates that. That's complicated stuff, right? And the patient often thinks, well, the doctor screwed up. Not always that simple. Yes, jump back in.
But,
I don't know if we're solving anything, but I did promise a candid conversation. Go ahead.
I think the big issue, though, is health information exchange.
Information
In other
exchange.
words, wherever that patient is, you're able to see their record, regardless of if they went to a private physician's office, they were seen in a clinic, they were in the hospital, so that if someone had a CAT scan yesterday and they were discharged from the hospital and they go see the doctor should be able to see that CAT scan so he doesn't order another one. So that's kind of what I think the exponential benefit of being able to get all that different information.
That's a positive.
That's a very positive.
By the way, Amy, go ahead.
But Pat started to talk about it. There are costs associated with that. There is a huge cost in creating that technology and having all of those linkages. And right now, in New Jersey, has the most physicians practice in what we call ones or twos. They're a single practitioner or they have a couple of docs with them. And so now you're saying to these guys, look, you need to take on $10,000, $20,000, $30,000 worth of costs. At the same time, I'm going to lower your reimbursement and try and figure out how you fit in the new healthcare world. And what you see are docs who have been entrepreneur, who stayed in their practices, now saying, look, I got to join with somebody else. I got to become part of a larger system
I need
or I
some
won't
economies
survive.
of scale here. I need somebody else to pick up the cost.
If you look at Bob and I, pediatric specialists cannot afford to practice alone. The hospitals hire them. Yeah. And so we have to pay that money to bring in those specialists. At the same time, the reimbursement
is falling. Bob,
let's
just say, Bob, this is not all. Everything we're describing here, and we're just scratching the surface, these are not all issues related directly to national healthcare reform. Some of them are, and some of them are systemic to the state of New Jersey and healthcare overall, correct?
Some of it is, but Steve, the idea of physicians joining healthcare systems and being employed by hospitals and health systems, I think certainly is being accelerated by healthcare reform.
Out of necessity.
Out of necessity. Between reimbursement cuts, between malpractice costs, between
the ACO.
The ACO.
Whoa, no jargon here, guys. What is that?
Sorry.
Go ahead, Joe.
The Accountable Care Organization. So the hospitals will be responsible for a group of patients. They're going to assign Medicare patients to us. All right, we're going to be responsible for the cost of that care. We're going to work with physicians to make sure that the cost of that care is reduced, and then we share in the savings. All right, and we split it back with physicians.
So that's not clear that they're going to assign them to us.
No.
There are insurers who are creating ACOs and saying to the doctors, cut the hospital out because the biggest savings will come to
ACO, we're getting into the weeds here.
So what's happening, Steve, just to pick up on that point, so that's going back to why hospitals are employing physicians and why physicians want to be employed by hospitals. Both parties are trying to prepare for this Accountable Care Organization, and you'll be able to really control the costs, if you will, and manage the care more efficiently if the physician is employed. Now, you have systems out there nationally, like the Cleveland Clinic, that has done that fairly successfully. But the devil's in the detail, again, because it's not clear that it's going to work. But certainly the healthcare reform legislation, which has this accountable care organization concept as a centerpiece, is driving physicians to be employed by hospitals.
Amy, I see you shaking your head, and you keep 20 seconds or less on why you disagree with Bob, and then I'll go to another topic.
It's not that I disagree. It's
yeah,
that
well, you do.
I do. The management of the care, just because you're employed doesn't mean you're going to be able to manage the care and have savings. At the end of the day, you and I have had this conversation many times.
You have.
It's about people's health, and it's about the things that we do to ourselves. Heart disease, if you look at the #1 rates of death, they're self-inflicted. And so really, if you want to have savings on it, you really need to have a conversation of, I need to go to my doctor and he needs to say, look, I know you've been carrying around that 10 pounds. You need to lose it or you're going to be at risk for, you already have a high-stress job. You need to get in there. My doc isn't going to say that to me because he wants to keep me as a patient.
Wait, time out. Hold on. Oh, wait a minute.
Well, I already
think about what you just said.
You are going back to your doc if he gets in your face.
Yeah. Well, but realize what you just said, Amy.
But
and
it's
by the way,
true.
the irony here is you and I have had this conversation many times, and Patricia as well. I mean, over 10 years, we've had separate conversations. I keep wondering, I know the conversation is different, but there are some of the same issues. Go back to the issue that Amy just said. There's almost like a sales and marketing thing. We talk a lot, Patricia, about how to retain the physicians you have and bring in new physicians at MD Advantage. Look at what Amy just said. If the physician is really candid with his or her patient, they say, I got the extra 10 pounds. If you don't do this, let me tell you something. There are going to be some problems here. Amy's saying from a sales and marketing and business development point of view, that's risky. From a healthcare point of view, that's the only thing that could happen. What are you telling your physicians? Don't be so candid?
No, we're certainly not telling them not to be so candid, but we don't have a lot of evidence that they are that candid. Right. The #1 thing...
They're self-censoring? Is that what they're doing?
I don't know if they're self-censoring or they're too busy to think about somebody's 10 pounds. But the #1 thing
well, that's metaphorically. We're not talking about Amy.
I said someone's 10 pounds. The #1 thing that we see in charts is very little documentation about what happened
in the medical charts.
At a history and physical, and patients talking about the fact, I wasn't informed of this, I wasn't informed of that, and no good documentation to defend what actually happened.
And you're attributing some of that to, hey, gotta move. There are economics here. The more patients I see, the more money I'm gonna make and may not get rich, as a physician. By the way, I can't tell you how many physicians I've had in here who said, if I knew then what I know now, And it's very depressing to hear that. I got 4 more minutes. I promise, Bob, I'll come back to you. Yes.
Let me just and again, I'm going to do the rebuttal from Amy's comments, but I don't disagree with what's being said. But I can tell you though, we at Hackensack we started to employ cardiologists over the last year and a half, and there's some national statistics that show within 5 years, 80% of all cardiologists in the nation will be employed by a hospital or a healthcare system. We're already seeing some efficiencies because they're employed. There's some standardization, some protocols that have been put in place. When they were free agents, if you will, in private practice, the costs were significantly higher. So I do think that model can lead to some efficiencies. Not always, but I think there is potential.
Does that reduce any med-mal insurance by physicians, cardiologists joining a larger group, joining a hospital? Does it change that dynamic at all?
We haven't seen any evidence of that. I think it's too soon to see that.
We've got 2 minutes left. I'm going to do this. Anything else about the current healthcare environment, 20 seconds or less, that in future programs, because healthcare covers a quarter of all of our program, and all on Capital Report, our sister program, one-on-one conversations we have with Governor Christie and others in state government, a quarter to a third of all of our programs are about healthcare. What else do we need to explore moving forward? Go, Amy.
I would say to you that the public doesn't understand that there will be changes that will ultimately impact them. How we talk about it, how we as providers figure out how to make sure that our #1 priority is getting people healthy and keeping them healthy. How that conversation happens over the next 48 months is going to be critical.
One of my producers, Bill Berlin, has been with me 22 years and said, Steve, will people snooze when we talk about healthcare because they think it's boring?
No.
No, why not?
No. Because it's about what happens to them when they're sick.
But don't we have to put it in that context? This is what it means to you? Because otherwise it's like, that's Washington, that's Stratton.
Which is why I think one of the big issues is understanding accountable care organizations, understanding what the impact on you as a Medicare recipient, how that's going to work, and I think that's a big
#1 issue, then I'll come back to Patricia. Go ahead.
The #1 issue I think that should be covered is the impact of healthcare reform on seniors and on the Medicare population, because it's going to be a dramatic difference. I think they're finally starting to wake up to that, but I think it needs to be covered more.
20 seconds, Patricia.
the whole culture of medicine is changing as a result of this, and I think that that's an important message to start to get across, that people's expectations of what they get will have to change, and making that relevant to me and to Joe and to Bob is one of the things that I think you could be very, very helpful with.
Patricia and Joe and Amy and Robert, I want to thank you so much. And also Michelle Fox, our new senior producer, her first show that she's in control, did a great job.
If you would like more information on this program, or if you'd like to express an opinion, email us at info@caucusnj.org and visit us online at caucusnj.org.